Hi, class. Last time we have talked about the general organization of the healthcare system, how there is often communication between the federal government and the provincial government, how the services are often provided at the provincial level, but the reimbursements or the fundings come from the federal government. So we have mostly talked about the healthcare services that are covered by Medicare or the public health insurance, also known as the Ontario Health Insurance Plan. Let's talk a bit about the private healthcare, the services that are covered by private insurance instead of Medicare. Private health insurance is offered by usually employers as a benefits package. It could also be purchased independent of your workplace from insurance companies. The private insurance covers services that are not included in Ontario Health Insurance Plan. So we have talked about the services that were not part of the pyramid last time, and those were some prescription drugs. Usually, these drugs that are covered by private insurance are medications that are related to chronic illnesses. These are not going to cover mostly the over-the-counter medications, but these are very specific to drugs that are necessary for maintaining health of the patients. And some other services include dental care or vision care, as well as physiotherapy, um, occupational therapy, or counseling, or some paramedical services. Ontario has private hospitals and clinics that offer a range of medical services, from diagnostics to surgeries to rehabilitation, and also some wellness programs. Patients can choose to receive care in these facilities for various reasons, including shorter wait times for certain procedures or specialized cares or treatments that are not available in public hospitals. The advantage of these private hospitals or clinics is that they are open during weekends and they often provide 24/7 phone care services provided by the nurses. And the assessments or the appointments that you have with physicians could be longer in time compared to the assessments that you get in public system. And also they provide preventative health examinations or screening, also genetic testing, to reveal the predispositions that you have, genetic predispositions that you have about certain illnesses. And they also provide customized travel care and consultations about office ergonomics, a variety of different services. Some prominent clinics, private healthcare clinics that are present in Toronto, in Ontario, are the following. There is Rosedale Wellness Center in Toronto, MedCan Clinic, or Cleveland Clinic. When you do research on the internet about medical information, then you are going to see Cleveland Clinic as one of the common resources in the search engine. Also, there is Healthcare 365. So these are some common private healthcare service clinics that are present in Ontario. The Ford government in Ontario is trying to expand the role of private for-profit clinics to deliver publicly funded services such as surgeries, diagnostic imaging, and also long-term care. Um, the reason why they are starting this project is because they want to reduce the wait times, especially the wait times that were um, the wait times that became so much longer after the pandemic. This strategy involves shifting more care to for-profit providers, the private providers, and away from the public hospitals, attracting significant debate over efficiency, staffing, and equitable access to services. So the Ford government is for publicly funded but privately delivered care. And they're putting, as I said, more emphasis on the for-profit clinics for larger roles. They're allowing these private clinics to run more surgical operations, such as cataract operations for your eyes, or hip or knee replacements, and also some screenings, such as MRI or CT scans. So some people question the the fairness of this type of system or project. And some people think that this is going to drain resources from the publicly funded hospitals and benefit owners of private clinics. In other words, the resources are going to come from the federal government, but the private clinics might offer unnecessary procedures to the patients in order to maximize their profits. So we're talking about some more screenings before operations are done, or more appointments with the physicians as a form of consultations in order to really increase their profit coming from the patients, or the reimbursements from the federal governments. If you look at this data, it shows us that 100% of the population, of course, have public coverage coming from OHIP. If you're a citizen or a permanent resident of Canada, then you have this coverage. Whereas only 70% of the population have private complementary coverage coming from your employers or independent private insurance companies that are going to cover services that are not reimbursed by the uh, public government healthcare system or government for the costs associated. So we're talking about, again, the vision care, dental care, prescription drugs, and also holding rooms in hospitals for for post operational stay in the hospitals. So you can see that about 30% of the population do not have the additional coverage for these necessary services that you need in life related to your eye health or your dental health. Now that we have talked about the organization of the healthcare system, and also the benefits and some downsides of supporting private healthcare systems, let's now look at the barriers that exist that hinder certain cohorts of the population from getting adequate access to care. We're mostly talking about the public healthcare system in this context. And these barriers that we will talk about are all related to the social determinants that we have talked about in class. As you can see in this figure, 1 in 10 Canadians does not fill his or her prescription because of the costs associated. These Canadians cannot afford the medications their doctors prescribe, so they decide not to adhere to the advice of the physicians. 66% of visits to Canadian doctors end up with prescriptions. So you need the medications associated, but a minority of the population is not going to adhere to the prescriptions. And Canadians are 4 times more likely to not fill prescriptions if they have to pay out of pocket. And this is common not only for people who belong to the lowest quintile in terms of income, but also to the middle class Canadians. Sometimes doctors are going to prescribe medications that are sold over the counter, and those are not seen as something that is a necessity for these patients. So sometimes they decide not to purchase those and just to endure the symptoms that they experience coming from acute illnesses such as cold or flu. Geography is another factor affecting people's access to care. Geographic distributions of the healthcare system or resources are uneven in Canada. One example that we have looked at before was related to the Indigenous lands, the territories that are occupied mostly by the Indigenous population, right? How they don't have access to a high number of specialists or even physicians in general, because the turnover rate for these providers or professionals is so high in those regions. And that is mostly because of the environmental conditions or factors that these healthcare professionals do not stay in the area for a long time. Canadians in rural communities, particularly the Indigenous people, have difficulty accessing primary healthcare. Another type of barrier is stigma or discrimination. So again, this is something that we have talked about before, but we are talking about stigmatization and discrimination in the context of the healthcare system now. Drug users, people who experience symptoms coming from drug abuse, or people with mental health problems, people who are very overweight, who experience eating disorders, or those who have sexually transmitted infections, those people who are homeless or transgender. All of these people are known to have fear about discrimination and stigma in the healthcare system, and they try to avoid the services as much as possible. So they are deterred from seeking healthcare because of the anticipated adverse reactions coming from the care providers. And these are happening at the individual level when they interact with the physicians or healthcare providers one-on-one. We often think that health outcomes in relation to healthcare system are mostly governed by individual choices, people not following the medical advice given by the physicians or not showing up for appointments. But that is usually not true. We must explore the inequities in actually accessing the healthcare system. Okay, the reality is much more complicated because the health outcomes are usually shaped by multiple layers of context. Um, and yeah, these layers of context that we will talk about using this figure here are going to interact with each other, uh, making some people difficult to get adequate access to healthcare system. This figure here shows three embedded contexts. The first is known as systemic context, the second is point of care context, and the third is social location context. At the largest level, we have systemic context. These refer to macro level political, as the figure says, macro level political, economic, cultural, and social structures that shape health outcomes across an entire population. Okay, so as it says on the left side, these are going to encompass the structures that drive inequalities. The common examples are going to include government policies, healthcare funding structures, or the inherent historical inequalities. Okay, so on the right side of the figure, it says structural violence that creates and sustains oppressions in health outcomes and access to care. Okay, so we are talking about inequalities that are persistent, okay, throughout history, and also the policies or healthcare systems that favor certain cohorts of people over the others. Okay, that allow oppressions within macropolitical, cultural, social, and economic contexts. The second layer is point of care context. So as you can imagine, these contexts are related to one-on-one interactions that patients have with the healthcare professionals. Okay, so these are related to the actual treatments people get when accessing care. This refers to what happens inside the healthcare system itself. So even when someone reaches a clinic or hospital, there may still be barriers such as institutional policies or triage decisions, language or communication barriers, provider biases, or specific administrative rules. Okay, so these are going to hinder some people from accessing care. The very last layer is social location context. Okay, so in other words, this is explaining the fact that who we are is going to affect access to care and health status. These include or these contexts are going to lead to oppressions within intersecting social determinants of health contexts. Okay, so social location context is basically your social location within the hierarchy affecting your access, your limited access to healthcare system. Okay, so this is related to all the social determinants that we have talked about in this class. A social location refers to where someone sits within social hierarchies, okay? And this is going to include determinants like income, race, education, whether you have disability or not, your employment, workplace conditions, all of those. These factors, the social determinants of health, are going to affect the health status, okay, and also the ability to access care. One example is someone who lives in a rural area. Okay, as we have talked about before, these people in rural areas may face fewer hospitals and they have to travel long distances to go to doctors' clinics, and they also have limited resources for specialists. Another example is someone with low income. Okay, they might struggle with transportation. Um, as we have talked about earlier in the course, they may have problems accessing care because of unpaid time off work or childcare while attending appointments. Okay, so these are all types of barriers and oppressions that could exist within the healthcare system. And all these contexts are related to the social determinants that we have talked about previously. Okay, now let's talk a little bit about health research. Health research is really important in the context of healthcare system because it is part of healthcare. The findings that you get from publications are going to be applied in healthcare settings, and you can think of health research as part of healthcare or healthcare system. Let's talk about some issues that are present in health research. In research, validity refers to how trustworthy or accurate a study's conclusions are. Okay, a study can collect a large amount of information, data, and sometimes still produce misleading conclusions if the validity is weak. And there are two types of validity that we have to pay attention to. One is internal validity, and the other is external validity. Internal validity is going to ask questions like, are the results truly caused by the factor being studied or by something else? So there has to be the answer of yes to this question in order to ensure that the findings are correct and accurate so that you can move on to the next type of validity and question whether these findings could be applied in real world settings. External validity is going to ask question of, can the results be generalized beyond the study sample? So there has to be truth in the study itself, in the findings that you get in the publications, in order for those findings to be applied in real life and for the truth to be there in real life. Okay, so there has to be generalizability of the findings in a study in real world settings in order for external validity to be present. Okay, so one issue in health research is validity, okay, whether it is internally valid and whether it could be generalized in real world settings. Another issue in health research is the use of proxy outcomes. A proxy outcome is basically an indirect measure of the desired outcome, which is itself strongly correlated to that outcome. Okay, so I'll give you one example. Blood pressure or cholesterol are proxy outcomes or proxy measures for heart attacks or cardiovascular diseases. It is known that when you have high blood pressure or high cholesterol, that is correlated to the probability that you're going to have heart attacks in the future or some kind of cardiovascular disease. Okay, so usually health research or the experiments that are done in the laboratory or in hospital settings are going to look at proxy outcomes instead of the real measures because it is easier to measure the proxy outcomes. And sometimes it is impossible to actually look at the initiation of diseases because that's not going to happen in a laboratory setting. So usually in experimental conditions, people are told to for example, eat some nutrients, some specific nutrients more, or to do more or less exercise. And then right after those treatments, these patients are going to be measured for these proxy outcomes, such as blood pressure or cholesterol. And those are seen as indirect measures for the desired outcomes, in this case, heart attacks or cardiovascular disease. But you have to remember that there are limitations in looking at the proxy outcomes and predicting the likelihood that a patient is going to develop certain illnesses or diseases. So the first issue with health research was related to mm, related to the validity, okay, internal and external validity. And the second issue is um, how these experimental studies are going to handle proxy outcomes much more than the actually desired outcomes, the actual desired outcomes. In this example related to blood pressure and cholesterol, you have to remember that approximately 70% of heart attacks occur in patients without high blood pressure or high cholesterol. So proxy measure of blood pressure or cholesterol is not always related to the incidence of heart attacks or cardiovascular diseases. Third issue that we have to pay attention to is the limitations of reductionism. Many of the times, experiments are going to look at certain factors independently. Okay, they're going to look at, for example, income, nutrition, or housing separately in order to look at the effect of these factors on health outcomes. And this is an example of reductionism, how you reduce all these interrelated factors to individual ones in order to um, make the actual experiments possible in the laboratory or in hospital settings. Because you cannot really study all these factors at once. That would be too complicated, complex, and it wouldn't really clarify the correlation that exists between one factor and the desired health outcome. So usually the concept of reductionism is used in health research settings. However, you have to remember that reductionism has its limitations, and also you have to be mindful of the caveats. Um, because usually reductionism looks at a particular factor. In many cases, the molecular causes, biochemical causes behind health outcomes. And in reality, um, health outcomes are influenced by a lot of different factors at once, okay, that are interrelated. As we have talked about before, there are many social determinants and environmental factors that affect the health outcomes of an individual. So you have to really take that holistic perspective in interpreting the data coming from reductionistic studies. Okay, so one example is the study of obesity. You can study obesity using a specific gene or some specific hormone, particular hormonal regulation, or some metabolic pathway. But in reality, these people who are obese are going to be exposed to a variety of different environmental factors. And you have to be mindful of that as a healthcare professional to take a holistic perspective because there are so many factors that are interrelated. Okay, so when you do health research, you have to be mindful of two terms, two limitations that could occur. One is oversimplification, okay, ignoring other factors that may contribute separately or concurrently from factor being examined. Okay, you have to be careful not to oversimplify the findings and also overgeneralization, ignoring diversity even among those individuals within a specific group. Okay, so in this section, we have talked about the organization of the healthcare system. We have made a comparison between the Canadian system and the system in the US, and we have found out that the Canadian healthcare system is more of a public good compared to the system that the US has. And also, we have looked at the characteristics of the healthcare system that we have in Canada, and also the limitations that exist, the barriers that exist in the health research field. Healthcare has become more effective over time. It has become safer and more accessible, but still, only a small minority of people receive it. Okay, it depends on geography, but also, as we have talked about, um, the preventative medicine is only going to target a portion of the population. And usually, people who actually receive the services in the healthcare system are people who are already sick, who need treatments. And not everyone is going to benefit from the system that we have. And health research contributes to our understanding of factors involved in disease, but research has its unique limitations that you have to be mindful of. That's all I wanted to cover today. I'll see you on Thursday for the presentations. Okay, see you next time. Bye.